I'm happy to speak to you. Dr. Athanakar has asked me to discuss diabetic retinopathy, specifically proliferative diabetic retinopathy. I am a retinal specialist. My name is Kenneth Wald, and I practice in New York City. I'm affiliated with Manhattan Eye, Ear, and Throat Hospital and NYU Medical Center. I've been treating patients with these kinds of conditions for about 25 years. We'll talk a little bit about proliferative diabetic retinopathy, and I'll sort of reprise a lecture I've recently given. Generally, I would probably prefer to have more of an interactive opportunity, but since I'm here and you're there, we will just go it alone. Obviously, this condition is a very important one for a lot of reasons. One, it's common, and two, it can be quite serious. The management of proliferative diabetic retinopathy actually hasn't really changed that much. You can see here, more than 25 years ago when I began training, pretty much diagnostically, the most important thing was a clinical examination. The diagnostic test that was most useful was a fluorescein angiogram, and it still is. Panretinal photocoagulation was the standard therapeutic modality to stabilize the condition, and vitreous surgery was used in certain circumstances, which we'll come to. The only change is perhaps now we have the anti-VEGF agents such as Lucentis and Eylea and Avastin. But in short, though there's been some refinements, the condition is treated in many ways the same as it's been treated for many, many years. Now, what makes it an important disease, first of all, is it's very common. Most of you already realize that diabetes is a very common disorder in our country, and it seems to be becoming more so. There's a problem with our diet and obesity, which are linked to type 2 diabetes. And as you can see, there's already over 25 million diabetics, which is getting close to 10% of the population, and quite a bit more. 80 million are pre-diabetic, and almost 2 million new cases per year. And all of you also know that the population is aging, and you can see in the older population over 60, the disease is even more prevalent. This is a very important slide, and it can help you kind of prognosticate patients. This comes from the Wisconsin epidemiologic study. You can see there's been 22 parts already. This is a very important ophthalmologic study, and it's been going on for many years. Back in 2008, they looked at the 25-year condition of diabetics, type 1 diabetics, which their onset can be dated very specifically. As you know, type 1 diabetes usually presents with a sudden illness, ketoacidosis, and therefore a precise dating can be made. And you can see the incidence after 25 years of having type 1 diabetes. Almost everyone is going to have some. And proliferative diabetic retinopathy, surprisingly, is at 43%. So close to half the patients with proliferative diabetic retinopathy, half the patients who have diabetes 25 years later will begin to develop proliferative disorders. If the patients present to you with proliferative diabetic retinopathy, there's a very high rate of mortality by 25 years, which is no great surprise considering all the other metabolic problems that come with it. And you can see the prevalence is really, as you can see in this arrow I drew in, the prevalence goes up with the years quite sharply. Sort of tails off around 30 years, probably because of the mortality rate. And as you can see again, these two lines show that you don't really start to see much diabetes, much proliferative retinopathy until about 10 years. And by 25 years, we're dealing with the incident rate that we show to the left. About 2% per year. Type 2 diabetes is not too dissimilar. There's also a relative. So you can see there's a very high incidence rate of proliferative diabetic retinopathy, not only because of its relatively high incidence after 25 years or so, but there's just a simply high rate of diabetes in our population. All of you who are going to practice ophthalmology are going to see quite a bit of diabetic patients and quite a bit of proliferative retinopathy. What we do know as well, which is very important, is that good control can certainly diminish the incidence of proliferative diabetic retinopathy. And that's why, as an ophthalmologist, we have an opportunity to really counsel the patients and do some good. The Diabetic Complication and Control Trial and its extension trial, which carried out the study 10 more years, looked at really good control and average control, which was considered a hemoglobin A1C of 9. In my practice in New York City, I see a lot of patients who have even worse control than this. In type 1 diabetics have a hard time doing much better than this, as do type 2s in many cases. Intensive treatment required 3 injections or a pump. And as you may all know, already taking care of patients for a few years, a great many patients, perhaps the majority, don't do a really good job, good enough to bring the hemoglobin A1C below 6.5. But you can see with intensive treatment after 6.5 years, there's a tremendous difference in the rate of proliferative retinopathy. And of course, it's by 16 years, it's 3 times lower. So you can certainly, with good control, reduce the rate of proliferative retinopathy markedly, and that's probably the first line of therapy, is talking to the patients and counseling them before they develop this complication. Now, the pathophysiology is pretty simple. Most people don't even talk about this anymore because it's so apparent. We all know that there's, because of the glycemic state, there's capillary non-perfusion. And this is something you can read about, the histologic changes that occur in the blood vessel wall. But ultimately, the non-perfusion causes the cells to elaborate growth factors, and there's angiogenic growth. And here's a slide where you can well see the typical appearance of the ischemic periphery. The non-perfused areas seem darker than the more perfused areas. And generally, you start growing these proliferative elements at the margin. And this is a fairly typical appearance. You can see at this above area of proliferation, a very clear capillary network that underlies this, and the kind of very intense leakage pattern, which makes fluorescein angiography so valuable in detecting early proliferation. And there's a close-up of the proliferative activity. Now, what is a little less appreciated even by ophthalmologists is that step 1 is the growth of these neovascular tissues, but step 2 is are changes that occur in the vitreous. The networks grow on the posterior surface of the vitreous. Eventually, those tissues become fibrotic and less vascular, more fibrotic, and more able to exert traction, as you see here, where some neovascular tissue, some fresh hemorrhage in the subhyaloid space, and ultimately leading to a fibrotic growth. Here's another example of that, where you have a neovascularization of the disc. Later on, you have this very white fibrotic membrane overlying the disc, and you can see the changes in the vascular tree, where it became quite non-perfused. So that's a very important change, is the initial neovascular growth and the later fibrosis and contraction of that tissue. Here's another example of a case. You can see first off that there's a subtle neovascularization of the disc. This is a type of neovascularization that one has to look for at the slit lab by examining the nerve, and then it would become apparent. You can see that there is a white threadbare arterioles, classic sign of ischemia. And of course, by fluorescein, you can see the severe non-perfusion, neovascularization of the disc and elsewhere. Here we're just demonstrating the growth pattern, and here you can see the growth has occurred, and then the lesion has become fibrotic, and actually a small hole is formed in the retina because of that tractional effect of progressive not only growth, but then evolution towards fibrosis. And here's a postoperative appearance where that tissue has been trimmed away. You can still see how white the overall blood vessels are, how ischemic this young diabetic is. Importantly, the pathophysiology includes changes in the vitreous humor. The vitreous initially is attached in proliferative cases. The neovascular tissue grows on its back surface. Ultimately, though, because of exudation into the vitreous cavity from the neovascular tissue, the vitreous separates except at the neovascular tissue. It then undergoes conformational changes and becomes more of a more taut. The hyaloid interfaces become taut and are able to create these tractional effects, as you see here, this cone type of shape in the vitreous. That's an extremely important part of proliferative retinopathy because those changes in the vitreous are necessary to create tractional detachments and in many cases to create the traction that will induce bleeding. And this is a slide I created when I first went into practice, and it shows the type of changes you see where you can have a cone of vitreous causing traction on the optic nerve head, a single point causing tractional detachment in the macula, or a very typical type of tabletop tractional configuration. And we'll get into that more in a bit. So in evaluating diabetic patients, you really have to be very not only thoughtful, but you have to be precise in examining these patients in the sense that first you have to say, you have to say to yourself, I'm going to check the iris for neovascular tissue. Then you have to do an overall global perspective on ischemia, and we'll talk about how that should be done and what you should look for, because that'll give you a sense of which patient should have further examination or further consultation or testing. I would recommend that you look very closely at the slit lamp with a 90 diopter or 78 diopter lens, scanning around, looking for proliferations, and also checking directly on the optic nerve to look for subtle disc neovascularization. And depending on those findings, further testing would be determined. Here's a gonioscopy of an angle neovascularization. Here's some of the subtle features you might see. It's just a few almost dot-like red spots, which are a very early presentation of proliferation or neovascularization at the iris or anterior segment. Here's a very obvious example of neovascularization of the disc. Everyone should be able to pick that up very easily, but sometimes it presents like this, where it's quite subtle. So unless you're really looking for it, unless you ask yourself, is there disc neovascularization? You can miss this. Is there iris neovascularization? You can miss this. The ones that look like this and the ones that look like this are a little bit too late. So careful examination would be indicated. Now, when you're examining these diabetic patients, the useful rule of thumb and the traditional one is to use that they ask you to kind of compare your patients to. It's sort of useful, but I generally look at it as a 4-2-1 rule, is 4 meaning 4 quadrants of dot and blot hemorrhages, and you just sort of get a feel for if it looks like more than a little bit. You see some deep blot hemorrhages, which are always a sign of ischemia, as are microaneurysms. So 4 quadrants of dot and blot hemorrhages, which is the dots are often microaneurysms, the blots are these dark hemorrhages, which are intraretinal hemorrhages. Venous beating, which is a change in the blood vessel calibers of the veins. That's a very strong sign of ischemia. And also IRMA, which is hard to detect and a little less useful. This is an example of an IRMA right here, right from their study. Cases like this are a little easier, where these deep blot hemorrhages, which are really ischemic infarcts in the retina. These type of deep blot hemorrhages are a very strong sign of ischemia. Here's an example of a venous loop. That's an interesting, you can imagine a very interesting occurrence, and I suspect it's related to capillary endothelial cell proliferations causing the blood vessel to loop in this manner, and the proliferation, of course, being VEGF inspired. Here's a case where you see the venous beating. Again, the blood vessels, as they travel through ischemic zones, sometimes will spasm and have this sausage-like appearance. Here would be a good example of IRMA. What happens in IRMA is the capillary perfusion is diminished in a zone and the residual capillaries become dilated. It's different than neovascularization in that fluorescein angiogram will not show leakage. These are not neovessels. These are just dilated residual capillaries in areas that are ischemic. So 4 quadrants of dot and blot hemorrhages, 2 quadrants of venous caliber changes, or a quadrant of IRMA. Any of those things should inspire one to either refer the patient to the retinal doctors or perform a fluorescein angiography, or at least to watch the patient very closely. Fluorescein is a very useful test. It may be the most useful use of fluorescein angiography, as some of the features of this disease are not well appreciated clinically. You get a sense of it by the examination, as I just mentioned, but sometimes the fluorescein will really show you just how ischemic they are, how poor the perfusion is, and frankly, you can see very well the caliber changes here. These areas that look darker than the adjacent areas, they look darker because the capillary network provides that kind of grayish white or ground glass appearance, and the areas that are non-perfused appear darker and featureless. You see here, if you look here, you can see a case where you might suspect ischemia. You can see the patient's had perhaps a little laser somewhere. This is some dot and deep blot hemorrhages, but it's almost inconspicuous that there's neovascularization at the nerve and elsewhere, and it's not subtle. There's a lot there, and you can see on the fluorescein how nicely it shows up as a bright area. Here you can see how well you can see the non-perfused areas, and the lack of capillary perfusion is well seen. Here's another example. Substantial non-perfusion. You can see how non-perfused the macular is, but yet in this example where you have a lot of cotton wool patch, you have cotton wool patches and even a whitish area here, there's no proliferation. And if you've noticed, when we mentioned the 4-2-1 rule, we didn't mention cotton wool patches. They're not felt to be a very strong prognosticator for proliferative disease, though they're clearly ischemia. Perhaps because of their longevity. Once they form, they can stay around a while. But here's a case where you see a lot of cotton wool patches, but yet this is not that ischemic a retina overall, and there is no proliferation. It's another example of a case where, what I was saying before, sometimes you have to really have a high margin, a high level of suspicion for proliferation. You have to look very carefully, because a case like this that you're looking at, this would be something like what you would see with a 20 diopter lens. It really doesn't look that bad. There's not a lot of dot and blot hemorrhages, and sometimes there is not. If you look very carefully with a 90 or 78 diopter lens and really scan the periphery, you probably pick up some signs of ischemia. But here, the fluorescein will show you a lot more ischemia than is appreciated clinically, and these areas of neovascularization elsewhere. Obviously a very important finding, and one that could easily be missed, and therefore, again, high index of suspicion for ischemia and proliferation, and a relatively low index for performing fluorescein angiography, which is so useful in detecting some of these spots of neo. Sometimes you'll see these on the fluorescein, and it's hard to find them in the eye. But here's very clearly, you can see the neovascular growth. You can sort of see the darkness out here, which indicates capillary non-perfusion. And there it is clinically. Again, you can see just how subtle this would be to detect in a clinical sense. Sometimes you'll see patients like the one I just showed you that don't have those dot and blot hemorrhages, and some people used to refer to that as a kind of featureless retina, where you don't see that much features because a lot of the blood vessels are missing. Here's an example such as that, where you see the blood vessels are white. So the blood vessels themselves are what give the retina its features. Without the blood vessels, it's just kind of an orange glow. So here's an example of a case where you have a lot of white blood vessels, and of course the presence of subhyaloid hemorrhage is a strong tip-off for proliferative activity. And this is the fluorescein of that patient. You can see these large gaps of non-perfusion, a very important kind of fluorescein sign to note, and the bright hyperfluorescence at the nerve, which is indicative of proliferative activity or neovascularization of the disc. So To summarize that, I'd say a very careful examination would be indicated. Signs of ischemia should lead you to strongly suspect proliferation, and further workup with fluorescein angiography or consultation. If you find these severe features based on the 4-2-1 rule, even if one of those features, dot and blot hemorrhages, half the patients can wind up with proliferative retinopathy in 4 years. Follow-up should be frequent. If they're very severe, meaning 2 of those 4-2-1 treatments, 75% risk of PDR within 4 years. And those patients, you could make a case to treat them because there's such a high risk, or just very close follow-up. Depending on how less severe it is, whether it's very mild or moderate, you can follow those patients less often, perhaps even once a year, depending on just how mild it is. Now, we're going to look a little bit about management. So far we've talked a little bit about how common this condition is. Secondarily, how the clinical examination is very important to detect the signs of ischemia, to detect the signs of proliferation, and how we could also use just simple counseling of the patients to control their sugar, which will reduce the incidence. And I think those 3 things could be really the mainstays of management. Those 2 things, the mainstays of management for general ophthalmologists, general comprehensive ophthalmologists. Treatment, I think, could also be in the realm of a general ophthalmologist, perhaps not the surgery, but we'll go from here to talk a little bit about managing this condition. So what do we got for treatments? We have panretinal photocoagulation. That's been used for this condition for more than 40 years. We have the anti-vasogenic agents, which are still not quite standard of care for proliferative retinopathy. Of course, for diabetic macular edema, it's probably now the mainstay of surgery. And then we have the vitrectomy microsurgery. Laser intervention. Here's a slide from the diabetic retinopathy study where you can see the laser is very intense, very posterior, and initially they would treat right on the proliferative elements. Probably this level of intensity would be a little bit rare today. You can see how close posteriorly this is, and obviously would have some symptomatic impact. We'll get into more modern treatments in a minute, but we'll look a little bit about this very landmark study, which all of you should read about and study and know pretty well. But as a very general sense, I've always thought of any patient that has disc neovascularization as at somewhat high risk. Now, the reality is what's considered high risk is greater than half the disc or greater than half the disc with vitreous hemorrhage. But pretty much any disc neovascularization is considered high risk, which means that untreated, you'll have this rate of severe visual loss. Obviously, patients who have disc neo and vitreous hemorrhage have a 30% chance of severe visual loss, which in this study is 2,800 vision, 2 visits in a row. Remember, this study is back in 1973. A vitreous hemorrhage in those days was a pretty severe event, as vitrectomy surgery was not yet developed. Again, here's I actually have to go back and just mention this is not disc neovascularization. This is neovascularization elsewhere and disc area. So only with neovascularization elsewhere, it's not considered high risk. You can look at these numbers. It's considered high risk only if there's associated vitreous hemorrhage. I'm sorry to have said it wrong. This is neovascularization elsewhere, which is in and of itself not an indication for treatment because it is a relatively low risk over 5 years of causing hemorrhage and visual loss. Whereas disc neovascularization is very much the opposite. Disc neovascularization, whether it's even without bleeding, if it's greater than 1/3 disc area, very high rate of severe visual loss. Obviously, panretinal photocoagulation diminishes that quite a bit. And you can see in those cases where there's a large area of disc neo and hemorrhage, very high rate of visual loss without treatment, and it's still kind of high even with the treatment. And this is from the from that study looking at that 1/3 disc area of treatment. Again, the numbers are probably not going to come up in the boards, and they're probably somewhat, as a general sense, notable to realize that disc neovascularization has very high rate of visual loss, and PRP lowers that very substantially, though not to zero. And again, the neovascularization elsewhere, which most people do perform PRP when they find it, small areas, generally not that high a risk. When there's associated hemorrhaging, high risk. So those are what they consider the high risk features: disc neovascularization or neovascularization elsewhere with hemorrhage. Now the results are shown well here in a graphical way. Those days there were two types of lasers. There was the argon blue-green, and there was the xenon group had a progressive and very steep slope of visual loss, whereas the laser-treated group with panretinal scatter had a much lower rate of visual loss. And you can see that the xenon is actually even better in preventing severe visual loss. It created very large burns, and the side effects, of course, were greater. But it does point out that sometimes heavier treatment will actually reduce further than lighter treatment the development of progressive neovascular growth, hemorrhage, and the other complications. And that is simply because the more laser, the more thoroughly treated, the less elaborated vascular endothelial growth factor, the less neovascular stimulus. So looking at panretinal scatter, which again, this study, the diabetic retinopathy study, was reported in 1973 and was probably conducted even earlier than that, a very, very long time ago. And what's new since then? Has anything changed? We're obviously still doing this treatment, and that itself is interesting, in that here we have a medical treatment that has lasted more than 40 years with little change. And it goes to point out just how effective this is. It's a very safe treatment, and it really works. I think the proliferative patients would certainly go blind without it at a very high rate. So the technique, I try not to go too posteriorly. I don't treat that heavily, as you saw in those pictures, and I'll try to do it on over a few sessions, just so the patients are not too uncomfortable. I very rarely would use a retrobulbar nerve block, though that was common back in the earlier days. Wavelength, we don't use blue-green anymore. It's mostly either argon green or a frequency doubled YAG. And basically, you can make a case in some cases for severe non-proliferative retinopathy or early proliferative retinopathy, though it's not been fully established, but you use your judgment on that. The only high-risk features are considered disc neovascularization and neovascularization elsewhere with hemorrhage. So, more modern technique, this is a laser that I had performed. You can see I stayed well outside the arcade and not too close temporally, and the spots are scattered around a lot less intensely. Patients can tolerate this better, and I think it's a little bit better as far as producing side effects. Here's a comparison between a more modern technique and the treatment from the diabetic retinopathy study. And frankly, this is also from the diabetic retinopathy study, very, very posterior treatment. And of course, the side effects are going to be night vision problems and visual field abnormalities. The other thing I would say about that is every patient is different. You have some young, very ischemic, very severe diabetics, and they should be treated intensely, whereas patients with much less severe disease, older diabetics, could have a little less treatment. This can be titrated to some degree. So the side effects, of course, if you're going to damage the peripheral photoreceptors to that degree that you've seen in those studies, you see it in some of those patients that were treated in the past, they're going to have night vision and peripheral vision abnormalities. Frankly, I very, very rarely see patients complain of either one of those things unless they're asked. almost never night vision and very rarely peripheral vision. Actually, very rarely peripheral vision and very rarely night vision abnormalities. I don't really see people initiating macular edema because of PRP, though that was a concern in the past. What is rare is sometimes because you are causing a diminishment in vascular endothelial growth factors, sometimes the neovascular tissue will regress quickly, leading to tractional detachments or hemorrhage. It's not infrequent that you'll treat a patient with PRP and they'll continue to bleed or bleed more. It's good practice to try to warn patients who need this treatment that they may actually get worse despite the treatment, even though ultimately without the treatment they would be much worse. So the treatment has always been shown without a doubt to be very important, very protective, but it doesn't mean it's 100% effective, and that the studies have borne that out. So it's very important to counsel these patients beforehand on the likely outcomes. Now we have this new technique, this new ability to treat these patients, which is with the anti-VEGF agents, all of which work pretty much the same. Now, Lucentis and Eylea are very expensive, and since the drug has not really been approved for the purpose of proliferative retinopathy, it's sometimes easier to treat them with Avastin. Again, it's not FDA approved. There are lots of studies, but no real controlled trial looking at these agents. We know that it works very well for macular edema from either diabetes or other vascular occlusive disorders. We know it's a standard of care for macular degeneration. Exactly where it's going to fit into the management of proliferative retinopathy is uncertain, but certainly you can see here's a patient I treated with extensive neovascularization. It's very bright on the fluorescein. One shot of Avastin, and a couple of weeks later, I repeated the fluorescein. And you can see the neovascular tissue no longer leaks. It rapidly involutes, and it could, of course, revitalize afterwards. This patient was treated because there was macular edema as well. But the neovascular tissue is very sensitive to VEGF, and it's very sensitive to its withdrawal. Here's that same case of severe iris neovascularization. A few days after Avastin, you can see the dramatic regression or resolution of the neovascular tissue with a single dose of Avastin. And later, I see this very same patient have an appearance much like the first picture as the VEGF starts to become elaborated again. So you can see that the use of that vascular endothelial growth factor, spelled wrong there, is very highly dosed in patients with proliferative retinopathy. The use of triamcinolone reduces it, and you can see with a shot of very occasionally I'll use it in proliferative patients as a preoperative treatment. Here's a patient you can see with a tractional detachment. There's vitreous blood, there's neovascular tissue, and a shot of Avastin was given, and this is the appearance it had right out a day or two later. You can see the neovascular tissue has become much more apparent because it's induced fibrosis, and now the patient has a detached retina. So you have to be very, very cautious about its use. And of course, this postoperative appearance to show that we ultimately did fix it, but it was a much more difficult surgery. So though VEGF inhibitors for proliferative retinopathy seem very, very enticing, you're getting right at the source of the condition, which is the elaboration of vascular endothelial growth factor. There are some concerns, and those are the rapid withdrawal of VEGF can lead to tractional or even regmatogenous detachments. There's some concern that you could be inducing more non-perfusion, since VEGF is a capillary or endothelial survival factor. And ultimately, these patients are very ill, and they have multiple systemic problems, and all of these drugs do get into the systemic circulation to some degree, and there may be some systemic concerns, though I have to say that I don't see a lot, and it hasn't really been established, but it has not, again, been looked at very closely in this population with proliferative diabetic retinopathy. So to me, I sometimes will use Avastin or the other agents that are available. Again, it's not established. There's no clinical trials that are blinded or controlled, but you can use it preoperatively to prevent bleeding, intraoperatively. So the preoperative use of the drug before you do a vitrectomy can be helpful. These days we have a lot of opportunities to control bleeding. The vitrectomy surgery is done with small gauges and with valve cannulas, so the hemostasis during surgery is a lot better than it used to be. Sometimes in patients with vitreous hemorrhages that are non-clearing and they can't have surgery, you can try to use VEGF inhibitors to stop the bleeding. You have to be sort of confident that there's not too much fibrovascular proliferation, because you can induce a traction detachment, and still yet it may take time for the blood to clear. I like to use it sometimes in late bleeding, some months or even years following a vitrectomy for proliferative retinopathy. Sometimes there'll be some neovascular proliferation that is not in the place that it was before because there's no more vitreous. So the neovascularization that can be induced post-vitrectomy sometimes is in the anterior part of the eye, what they call anterior hyaloidal fibrovascular proliferation. And in the past, some of these patients would undergo multiple vitrectomies to clear blood. Now I think the use of Avastin is very efficient for that and can avoid some reops. So to summarize, we have the treatments of proliferative disease, which include first and foremost the panretinal photocoagulation, which somewhat depends on having a clear media, examining and finding these patients at an earlier juncture in their disease, before they have vitreous hemorrhage, before they have traction detachments. The judicious and sometimes intensive use of panretinal photocoagulation is usually curative. Our second treatment, which is not firmly established yet, is the use of the anti-VEGF agents. Their use is probably valuable in many circumstances, and we may learn better just where they should be used. But at this point, I'd say some caution should be exercised in using them. And then, of course, the treatment that is utilized if the patients are losing vision from either hyaloid interface processes, as I'll show you in a moment, or traction detachment, or non-clearing vitreous hemorrhage, is the vitrectomy surgery. And again, this surgery is this has been around now since probably the late 70s, early 80s. So it's a pretty new treatment, and it's in a state of evolution. In the past, the results of this surgery were not very good. Now they're extremely good, and much we can get much better results and a much lower complication rate. Here's a typical case of a diabetic traction detachment. You can see at this point in the disease process, the patient has had laser photocoagulation. The neovascular tissue looks to be largely white or regressed, which is a late stage. You can see some of these sheets of white tissue are contracted posterior hyaloid interface, and sometimes it sticks, to the macula, as you can see in these OCT images, and one can clearly see that the retina is elevated. And this is a postoperative appearance. At some point, maybe I could have we can send some videos of how this looks. But here we can see we've basically used a scissor and cleared out all this tissue, and the retina starts to slowly reattach. Here you can see it's still, even postoperatively, still has subretinal fluid, but months later that resolved. Here's a patient with a condition we might refer to as a posterior hyaloid face, a taut posterior hyaloid face, and the proliferative tissue is still active. It's growing on the posterior hyaloid face. You can see it's this sort of a white sheet overlying the macula. Here's the OCT. Again, the linear, in this case, tissue plane. The retina is thickened. There's subretinal fluid. This is a horizontal cut. This is the vertical cut. And here's the fluorescein, a very active proliferation, this edema of the macula. It's a close-up of that. You see this kind of cystoid look about the macula. And here's the postoperative appearance with delaminating all that fibrovascular proliferation. You start to get the normal foveal umbo and improved acuity. That was the pre-op. cataract surgery in terms of determining that. Clearly, sometimes if a patient has bilateral vitreous hemorrhages or poor vision in the other eye, they're rendered severely incapacitated, and more prompt surgery is probably indicated. I usually try to wait at least a month to see if the hemorrhage will clear. Again, there's no hard and fast rule. Certainly after 3 months or so, there's some risk in leaving a dense hemorrhage as the proliferative activity can progress, and tractional type of problems like such as attraction detachment can occur while you're in the observation mode. So the patients should be watched closely while they have vitreous hemorrhage. One should examine the iris for neovascularization, ultrasonography to determine if there's tractional effects, and consideration of their health and their fellow eye is paramount. Also important is whether they've been treated in the past. And this is a patient that we waited a little bit. You can see the hemorrhage, slowly waited for the image to come. The hemorrhage cleared up on its own. A lot of times if you're watching these patients and you start to look at them with an indirect ophthalmoscopy, you'll start to see the vitreous starting to take a kind of organized appearance, and that is almost always a bad sign that traction is taking place, and you can see that on an ultrasound quite nicely. The history is important. If they've had no panretinal photocoagulation, I would generally feel they should have treatment a little bit earlier. If they've been well treated by PRP, and there's not a lot of fibrovascular tissue, it's less of a high risk situation. If they have a lot of diabetic macular edema, obviously it's harder to treat that if you can't see it. The retinal findings by ultrasound are important. The vitreous anatomy by the clinical appearance. What's the condition of the fellow eye? Is there anterior segment neovascularization? Obviously that's important. And sometimes the age of the patient is also very important. In young diabetics, early treatment can sometimes yield a much better visual result. That's probably because they have more aggressive disease, and earlier treatment can certainly allow more thorough and prompt photocoagulation, and that was shown in the diabetic vitrectomy study, which was a somewhat flawed study. In the era that it was conducted, there was no endo laser, and they had an extremely high rate of rubiosis and complete visual loss. But you can see here in the younger diabetics, they had a tremendous improvement in their outcome with early vitrectomy. This is to achieve a 20/40 or better visual outcome. So in short, I wouldn't draw too much conclusion from the diabetic vitrectomy study, and the only thing people usually will quote from that is that younger diabetics probably should have a little bit more consideration of prompt surgery. So the indications for vitreous hemorrhage, a case like this where you have this fibrosis growing on, this is a subhyaloid hemorrhage. And some cases where you have that, you'll start growing this fibrosis will begin to form over the macula. Once that gets far along, it makes the surgery more difficult, so I might try to operate on those patients a little more quickly, as you see here. If you have massive fibrovascular proliferation, such as this kind of case, again with subhyaloid hemorrhage, it's very unlikely that patient is going to do well without surgery. How do we do this surgery? We always know that the disease is really at the vitreoretinal interface. That's where the neovascular tissue is. I won't get into this too much, but we try to basically truncate the vitreous. And this is, like we talked about earlier, how the vitreous is an important actor. It becomes separated from the retina. The fibrovascular proliferation is adhered to the vitreous. So the first step in vitrectomy is we try to separate the vitreous from the anterior vitreous, from the posterior vitreous. That simplifies matters. Then we sort of cut across any elevated areas, leaving these little islands, and then using a scissor we can delaminate the residual tissue. And of course we try to apply laser PRP at the end of that. A lot of times we'll look at these cases, we'll see vast sheets of fibrous proliferation are really held to the retina by a single point where the condition originated from. Unlike cases of epiretinal membrane from other causes, these membranes can't be fully peeled. They have to be cut. If you try to pull one of these attachments, which retinal surgeons call pegs or tacks, you'll tear the retina. So you can see something like this neovascular tissue could have a single point of attachment. Here's an example of a case with fairly widespread proliferation. And I did a vitrectomy and just left these little islands. The whole thing can be peeled off except these little islands are residual, and that points a lot towards the kind of pathophysiology involved here. Again, large, almost the whole posterior pole covered by fibrosis, which you can see on the OCT. And ultimately, you can dissect this into just a few little islands and remove all that tissue, just leaving these little islands. They can be removed by a scissor, but sometimes you can just leave it as is. So the surgical keys, you try if possible. Sometimes the hemorrhage will prevent that. Full PRP, because that sort of stabilizes the condition and makes surgery a little more safe. Preoperatively, sometimes doctors, I do less often, but it's an area of some controversy. Preoperative anti-VEGF treatment, again, it involutes the tissue. That can certainly help you with intraoperative bleeding. But if you wait too long, you can get a tractional detachment because of the profound regression of the tissue. I always try to get a medical clearance intact before I would ever do this, because I don't want the cases to be delayed. One has to always be conscious of the crystalline lens. The lenses in diabetics sometimes will cloud up after about an hour of vitrectomy surgery, and certainly if they've started with a bit of a cataract and it's a difficult surgery, you may want to render them pseudophakic beforehand, because it's probably very bad for them to have a pars planar lensectomy, which could allow things like rubeosis to of diabetic macular edema. Try to work efficiently, maintain the hemostasis with the new systems that we have, 25 gauge or even lower gauges like 27, which are coming on. The ability to have a constant IOP is improved. They're valve cannulas, so when you switch instruments, the IOP remains stable. And anytime the eye pressure goes low, as you may know, you're going to risk bleeding in any type of surgery. I try to remove as much the vitreous interfaces as possible, as much as the fibrovascular proliferation is as possible, and you use judgment for that, because if you're too aggressive in some cases, especially with peripheral tissue, you might create a retinal break, which changes the management quite a bit and the prognosis, and a completion of the PRP is almost always undertaken. Here's a patient that was quite ischemic. You can see was seen in 2012. You can see dot and blot hemorrhages, and the fluorescein angiogram really demonstrates just how peripherally ischemic it is. Again, this is very important to notice. This kind of whitish gray appearance posteriorly is perfused retina, and the kind of dark, featureless appearance outside of that is a clear sign of ischemia, and you can see there's some neovascularization. Clearly, this patient received panretinal scatter, but was lost to follow-up and didn't come in for 10 months. There's some PRP, but not nearly enough. Now one can see that there seems to be a white sheet over the macula, a little bit of hemorrhage. You can see the ischemic blood vessel. And the fluorescein shows just the posterior pole is just covered by a fibrovascular proliferative growth. It's interesting to see that this, you can't fully even appreciate just how vascular it is, because there is a fibrotic matrix or with it. You see just how vascular that membrane is. And of course, that's a patient who underwent a surgical approach, and here's the postoperative appearance. Again, a scissor delamination with one little island of fibrosis residual. Large subhyaloid hemorrhage, and here's a postoperative result of that. What are the complications of it? Many cases can have recurrent vitreous hemorrhage. A feared one would be a complete retinal detachment, neovascular glaucoma, and if these cases are not done well and there are retinal breaks that are not well treated, their retinas can detach. Once the retina detaches in some of these diabetics, the elaboration of vascular endothelial growth factor can be enormous. neovascular glaucoma and ultimatitis, and that was a very common outcome in the early days of vitrectomy surgery. Much better now. Here's a patient with a tractional detachment, combined tractional rhegmatogenous detachment. There's a little hole right here. You can see the retina was elevated. I did a vitrectomy. Looked like a nice job. However, she formed a macular hole. I'm not sure if it's exactly a complication, but that was the result. Ultimately, that had to be fixed as well. So I would summarize the management and the concern of proliferative diabetic retinopathy in a couple of ways. First, it's a major eye disease. It's common, becoming more common. We can see it in young patients, which always makes it somewhat more important. I very frequently will be managing patients in their 20s, 30s, and 40s, still in their active, productive years. The mainstay therapeutically is panretinal scatter photocoagulation, which is being, here are some of the things that were happening back in 1971. Richard Nixon was president. John Kerry was an anti-war protester. Disney World opened. Here's what cars look like. For those who can't remember that, vitrectomy techniques are really very much the same, but they're evolved. Smaller gauged valves for IOP control, and just better techniques and understanding of how to do it. The role of VEGF is uncertain, and one other point I would make is just the well-established efficacy of good glycemic control, which may yet be the